So we're going to go ahead and get started, even though we have some people still lingering out in the hall. I'm hoping those discussions are getting wrapped up because you're not going to want to miss this next discussion. This next one revolves around safety initiatives in the jockey, and we'll hear from 3 experts in this field. Dr. Peta Hitchens is the first one who's going to come up here on stage. Dr. Peta Hitchens is a research fellow in equine veterinary epidemiology at the University of Melbourne, Australia. She combines expertise in epidemiological research of equine and human health, safety, and welfare with experience working in the racing industry and regulation and operations management. In 2016, Dr. Hitchens joined the University of Melbourne's Equine Orthopaedic Research Group, a multidisciplinary team that aims to determine the causes of musculoskeletal injuries in horses by developing mathematical and epidemiological models of bone biology processes. Their primary goal is to work alongside the racing industry to develop evidence-based strategies that reduce the occurrence of such injuries. So it's Dr. Hitchens's cross-faceted experience working among industry, government, and academia that has driven her viewpoint on the importance of collaboration, which is why she's here, in order to ensure evidence-based strategies are employed to benefit the health, safety, and welfare of horses and their riders alike. Our other expert is Dr. Carl Mattacola. Dr. Mattacola is a professor and associate dean of academic and faculty affairs right here at the University of Kentucky, and I've been to his lab, and it's fascinating. If you ever get invited to visit, you should. Dr. Mattacola's research has focused on postural and functional considerations in the treatment and rehabilitations of lower extremity injuries and the study of cognitive, functional, and safety interventions for jockeys. He is the director of the newly created Jockey Equestrian Initiative of the Sports Medicine Research Institute. Thank you, Dr. Mattacola. And then third, we've got Dr. Kelly Ryan. She's the primary care physician in sports medicine at MedStar Health. Since partnering with Maryland Racing 3 years ago, Dr. Ryan and a team of MedStar Health physicians banded together to form MedStar Horsemen's Health, a program designed to monitor the health of jockeys and other racetrack personnel at Maryland racetracks. A national spotlight has been fixed on their healthcare model since they designed and implemented important concussion protocols. By conducting baseline tests with jockeys before they are injured, they can best determine who has a concussion and if he or she is ready to return to ride. And Dr. Ryan hasn't only worked with our equine athletes, the jockeys, she's also worked with players in different sports like basketball, lacrosse, and of course football, as they also experience a high rate of head injuries. And so you all can go ahead and begin.
Thanks, Donna. I believe the box was for me, so don't feel bad about that. Oh, am I going backwards? Aha. And keep going with the green? Nope. So we all know that the hazards of horse racing are well known, and in fact a US study several decades ago found that it was the most dangerous, or one of the most dangerous occupations and sports in the world. And over the last few decades, especially in Australia, the racehorse fatality rates have actually been relatively stagnant. In a couple of states in the US, there have been reports that these fatality rates have decreased a little bit, but overall, there hasn't been much movement in that area. And we know from 2 studies that have been conducted over the last couple of years, one in California and one in Australia, that the most common reason for jockey injury and fatality is actually when they've been riding a racehorse that has broken down under them. The issue that we've got is that there's a lack of an evidence base for risk factors for jockey injuries and fatalities, and there are conflicting evidence base for the risk factors for racehorse injuries and fatalities. So we really have an issue in coming up with practical strategies to try and reduce some of these issues. So in Australia, we have 800 jockeys that are licensed to ride each year, and we see 2 jockey fatalities every year. So that's 1 in 400 jockeys licensed to ride a year. In the US, it's quite similar. We see a couple of jockey fatalities each year as well, and the number of career-ending or paraplegic injuries are even higher than that. So in Australia, since 2014, just the last 4 years, we've seen 8 jockey and track work or exercise rider deaths, and 5 of them, so that's over 60% of those deaths, were a direct result of those jockeys or exercise riders riding a horse that had sustained a catastrophic musculoskeletal injury. So we know a few things. Globally, we know the incidence of jockey falls and injuries. In Australia only, we know the risk factors for jockey falls and injuries. We don't know those for the US as yet. And in the Californian and Australian study, we were able to confirm the linkage and the relationship between racehorse fatality and jockey injury. So globally, the incidence rate for jockey falls per 1,000 flat race rides is quite similar. In Australia, about 4 falls per 1,000 flat race rides, a little bit lower in New Zealand. In the UK, Ireland and France, it ranges from about 3 to 4 falls per 1,000 flat race rides, about 2 falls, but during races only in Japan, and in the Californian study, about 2 falls per 1,000 flat race rides. Even though the Californian rate looks lower, it's because the falls that occur, especially in Europe and in Australia, over 50% of those are actually occurring pre and post-race, whereas the majority of the falls that are occurring in those reports from California, for example, were actually during race falls, which are generally much more severe. And we can see that reflected in our injury rates. It's actually very, very consistent across all countries. There's about 1 jockey injury per 1,000 race rides for all of those countries. What we've importantly found in our Australian study were risk factors for jockey falls and injuries. And what's important to note here is that none of these risk factors are independent of each other. So if a jockey is ticking multiple risk factor boxes, then that risk becomes cumulative. So for example, an apprentice jockey has about 50% higher risk than a full licensed jockey when they're riding in a race. This risk increases if they're an inexperienced apprentice jockey that has had about less than 250 race rides, so typically in their first or second year of riding. When you place that inexperienced apprentice jockey on a less accomplished horse, for example, a maiden horse that hasn't won a race yet, or on a horse that has had less than 5 race starts, the risk accumulates even further, and we actually found that the accomplished and less experienced horses were more important than the horse's age. If you have an unraced 5-year-old, that will be a higher risk, for example, than a 2-year-old that's already had several race starts. A less experienced jockey riding a less experienced horse in a sprint race or on a drive-fast turf track, and in Australia most of our racing is conducted on turf, again exasperates that risk. And that's mainly because those races are obviously run at much faster speeds, and the jockeys are racing in much tighter, closer proximity to each other. So if a horse does come down, they're more likely to be struck by the horse they're riding or others following. So what we didn't know from those Australian studies was basically the link between racehorse injury and fatality and jockey injury and fatality. And it's obvious, really, if a racehorse comes down or breaks down, it's likely that it's obvious that the jockey will also come down with that horse. So the risk factors should be linked, but we haven't yet actually conducted studies that link those risk factors together. So in a study funded by the Californian Horse Racing Board, we collated about 6 years' worth of data for the California Jockey Accident Database, and this consisted of about 300 jockey injuries, over 600 falls from 264,000 race rides. And these jockey injuries and falls were collated from the jockey accident reports that are put together by the stewards on race day. And then we linked this data with the racehorse fatality data from the California Horse Racing Board Post-Mortem Examination Program database. So that was the first time that we were able to see a linkage. What we found was, as I said before, the majority of falls in the US occur during the race. This is very different to other countries where more falls actually occur pre or post-race, even though they're less severe. Nearly 25% of the falls are on leaving the starting gate, and much fewer in the paddock and post-parade and after the finish. So importantly, we did find that the leading cause of jockey falls was riding a horse that had sustained a catastrophic musculoskeletal injury or sudden death. So that was over 30%. And in quarter horse races, even more so, it was closer to 40%. Of those jockey falls that were a direct result of racehorse fatality, over 60% of those resulted in injury to the jockey. That was much, much higher than those that were for other reasons, for example, for the horse's behaviour. Again, that was closer to 40%. The most common jockey falls associated with racehorse injury, we would expect it to be, you know, those racehorse injuries and those racehorse fatalities that have the highest prevalence. So those are our distal forelimb injuries. In California, there's about 40,000 race rides per year. So we would see about 23 jockey falls per year related to riding a racehorse that has sustained a catastrophic distal forelimb injury. Other injuries that were quite common were bilateral injuries, multiple injuries, and axial injuries. And those injuries commonly resulted in a jockey injury because obviously the racehorse was more likely to fall down and come down on the track. Our other causes, most importantly, horse behaviour, stumbling, particularly out of the starting gates, clipping heels with a horse racing in front, shifting ground abruptly, or being hampered by another fallen horse or rider. And in Australia especially, we actually found that almost all of the falls that were associated with pre-race falls were a direct result of the horse's behaviour. So it was the horse either bucking or rearing or bolting, causing the jockey to fall. And this isn't just an issue for the jockey's safety, but also the horse's welfare. Obviously, if a jockey comes down during the pre or post parade, that horse becomes loose and can injure itself. And although these types of falls are normally not as serious in nature, we did see a couple of decades ago one fatality in our paddock, in our mounting yard, where the horse reared up and fell over on top of the jockey. We see less of these horse behavioural issues, I guess, pre-race in the US compared to Australia, and we think that's most likely because of the use of lead ponies. In Australia, we don't actually use lead ponies, so we have, you know, over 50% of our falls occurring pre-race, and we think that's probably the likely cause. Importantly, not just the incidence rates, but the actual insurance claim costs. This data is from California again, from 2007 to 2012 from Finish Line Insurance Group. And they see about US $1 million per year in insurance claims for race day jockey injury costs, and that's about $20,000 per claim. When we just look at those that were a result of the horse that they were riding breaking down, that claim goes up to, on average, $100,000 per claim. So we can see how serious these falls, when they're associated with a racehorse fatality, are. And it really is just the tip of the iceberg as well. Very, very few studies have actually looked at the exercise rider or track work rider, but the costs are actually threefold those for exercise riders than they are for jockeys in California, with claims averaging about almost $30,000 per claim. So just to conclude, we know the incidence of injuries globally, so we can compare these. We can look at the different risk factors between these. We have a number of readily modifiable risk factors, although only for jockey injuries in Australia, not yet for the US. but we have had a number of studies globally for racehorse injury and fatality. We know that a high proportion of jockey falls and injuries are caused by horse fatality, and that these falls and these injuries are very, very high cost, and that they're just the tip of the iceberg. We don't have as much information on exercise or track work rider falls and injuries. So what can we do to try and prevent these? So the main things are looking at the risk factors that we know we can make a difference in, and that's ensuring that the horses are thoroughly acclimatised and educated, especially when we're looking at such a high percentage of jockey falls that are related to behavioural issues. It generally suggests that perhaps these horses aren't acclimatised and educated enough to actually be running on race day. Again, ensuring the horse and rider combination are well suited. Putting a very inexperienced jockey on a very inexperienced horse is a recipe for disaster. Being vigilant when training a horse that is at a higher risk than normal for injury, which I think Professor Tim Parkin will cover a little bit later. And then preventing those most common racehorse injuries and death, for example, fetlock injuries, which were the main cause for jockey injury and fatality as well. And that's trying to address a number of things that we know we can address, avoiding under or overtraining, putting in place better regulations for medication restrictions, and managing our tracks better. And I think one of the most important things for me has been the standardisation of record keeping and regular analysis of this data. We will never know whether or not our interventions are successful unless we're able to go back and actually look at whether or not the incidence of jockey falls and injuries and racehorse fatality has actually reduced. And the reasons for those reductions. And once we know that information, we know what sort of strategies we can try and focus on to try and bring those rates down even further. Thank you.
Okay, you want me to do that? I can stand on that. Good morning. Thank you for the opportunity to come to speak to you today. I want to talk a little bit about really three things. Talk about an update on our pilot study that we've been conducting as a result of some of the funding from the industry for the last 3 years, really 2 years, coming on our third year. Discuss some future considerations related to medical care and medical management, and also tie into that research considerations and clinical considerations that have evolved from this interaction, both with the pilot study as well as some of the opportunities that have presented themselves as a result. U.S. horse racing is one of the only organized groups that really doesn't have a complete, comprehensive concussion plan. And part of that is the organizational structure. And you know, it's important, I think, for me to identify to you all that horse racing is not my profession. So my area is actually in sports medicine. And so I'm going to try to draw on some parallels to some of the other organizations and some of my experiences in those fields. As I look at it and as I watch the last few years of the work that we've done related to pilot study and coming to this conference, some of the challenges are similar to any profession. There's a resistance to change, particularly if that change involves the potential for additional dollars or for structure that may not be there, and how to get that structure in place. One of the other interesting things I've said as I've been a part of this is that horse racing is really regulated from a state level in many regards and doesn't have a national body. And there are some disadvantages to that, I think, when you get into some of these areas. Another area that's interesting and really sort of has evolved is there's a lack of a medical advisory committee. And then there are challenges with your accreditation model. I've been a part of a profession where some of the programs were voluntary accreditation, evolved and were part of a voluntary accreditation. And that's very similar to your accreditation, which means that the organizations that buy into that accreditation model are voluntarily doing so and are not required by the NCAA, the NFL, NBA, or some governing body. And so there's some challenges with that. So the purpose I wanted to identify is the pilot study that we conducted and have been conducting and still conducting is really related to identifying how to put in place an effective management protocol at the local level for and particularly related to head injuries and concussion. So as most of you know, concussion has changed the way that we look at sports. There are rules and there are regulations and there are models and there's research and there's dollars that have flowed into professional and amateur sports like no other condition that's ever been presented. The long-term implications are serious, and we still don't know a lot about the long-term implications of head injury. And that, when you start getting into medical dollars and thinking about the long-term impact on sports in someone's individual life and functional ability, that's significant. So what we've done the last several years is worked on creating a standardized baseline assessment primarily in Kentucky. So as I watched the concussion protocol develop and evolve in horse racing a few years ago, it was obvious that it would be really difficult to do this from a national level. So the idea was we'd start it locally and grow globally. And we collected baseline assessments on 70 jockeys in 16, 31 in 2017, and another 30 this year in 2018. Those were primarily conducted at Keeneland, Churchill, Turfway, and Kentucky Downs. And so we administered the CAT3 and CAT5. That was administered to all the jockeys with the implication that they would be tested on a 12-year cycle or retested on a 12-month cycle, a 1-year cycle. In addition to capturing that baseline concussion information, that was uploaded into the Jockey Health Information System, and their health information was updated. So it provided a formalized way of capturing those individuals. So how did we do? Some cool progress. So Keeneland last year made it mandatory that any jockey that participated here on grounds would have to have a CAT5 or CAT3 assessment on record, or they wouldn't ride. So that was creating a pretty significant standard, I think, for much of the industry to follow. Similar to Kelly at MedStar, they require that jockeys that are participating under their governance and their oversight has a baseline concussion. So check that off. That was a cool thing. We've also had a group of medical advisors. We sort of loosely a committee or advisory group that we've met regularly, and some of the implications of that is we help to develop the model guidelines for concussion management and return to ride protocol. The other part of what's happened locally here at Keeneland, when we look at the process that's taken place because of our pilot study, one of the things that I was really proud of this year, it was the first time that we pulled together all of the entities, because it was mandatory, to really talk through an emergency management situation. So the medical director was present, the athletic trainer was present, the stewards were present, EMT, the medical management plan related to a concussion and how it would be treated and managed was talked about. So that line of communication that many of the talks talked about this morning today actually took place. So that was an advantage to, and sort of a check off of accomplishment that I was proud of. In addition, I mentioned our advisory group where we've identified consistent protocols and we've shared ideas and challenges among the group. Likewise, we work together to promote and write the guidelines for concussion management in medical care and the return to ride guidelines. That was approved by the Jockey Guild Board of Directors and was recently established as a model rule from the ARCI. And so that basically sets a minimum protocol that an assessment protocol should be in place at tracks, and there should be a healthcare provider who's trained to be able to provide that, as well as have some return to ride or some return to participation protocol in place. So that's huge. That's an important piece. Other evidences of completion from our pilot study, we've had 5 national presentations. We've had several presentations at the International Conference in Berlin, several presentations last year, manuscripts under review. And I think one of the things that some people don't realize is it really has been a shared collaborative effort. So about 60% of the dollars from the pilot study came from industry, and the other 40% have been funded under the University of Kentucky, specifically College of Health Sciences, Sports Medicine Research Institute. So I appreciate all of that, those provisions to make this happen. And then in addition, some of the exciting things that we've had take place is we have approximately $150,000 that we've invested in a laboratory to further some of this testing and further some of the work that we've started. So as I look to the future, and we look to the future, and we think about improving medical management, that's an important piece. The integration to national accreditation standards and then the implementation of those standards so that it becomes commonplace among tracks, that's also another future goal. Better organization of the medical management and education, I think a vital, important piece as we develop the infrastructure in place to provide for care of jockeys and their health care. And then obviously the sustainability, that's one of the pieces that as we looked at tracks, how can we do this? How can we put this model in place so it's sustainable? Other additional things that are related to the medical management, further refining the information system. So we've been working on identifying how to improve the jockey health information system, tying that into the injury database that has been in the works for several years. And there's several groups of academicians that are meeting in the next couple days to talk about how we can improve that and how we might continue to integrate that, as well as the use of technology to improve access to the data. So those are all, I think, important parts for the medical management piece. The model rules, a model rule has been established. Now is the hard part. Now is the part of getting it integrated and making it commonplace. And to me, that's a change in culture with consistent repetition. So the goal really of our model was to develop something locally that could be sustained globally throughout the United States. Part of that, and part of the way that we can do that is certainly the contact of those medical health providers, coordination and integrating those individuals that are at tracks or that would be identified as being responsible for providing health care. And as a part of that, vital, I think, to any time you have a group or committees is organizing the clinical and education priorities around that. So not burying our head in the sand and saying, well, this is the way that racing's done this forever. I want to present a few ideas related to how some of the other organizations do that. If you think about medical management and some of the other professional organizations or amateur organizations, some people would argue that the NCA is not an amateur organization when you look at the dollars that flow in and out. But how the NCA deals with the medical management piece is they have a separate group that's independent. So they have the NCA Sports Science Institute, and their goal or their priorities is to work with the medical community and member schools to promote the administrative structure to guide medical management. So it's independent of the group. That's one model. Another model just to propose is the NFL works in subcommittees. So the NFL continues its work. It combines the NFL Players Association, NFL Physicians Society, and professional football athletic trainers, as well as several experts, to identify and implement changes on and off the field to protect the health and safety of every player. And they do that through subcommittees. So they basically create subcommittees that would have a charge that would bring information back and provide the best evidence for practice. So what I've done, and this is, I'm open to all criticism of this, but I just wanted to get down on paper and think about what would a medical management system look like in racing. And to me, one of the thoughts would be you would have a medical advisory committee. You'd have a medical director that would work with that medical advisory committee to oversee and help implement any changes and procedures and protocols that would take place in the industry. And then you would have a coordinator that would coordinate and be the person who would be the liaison for all the healthcare providers that are at different tracks. And so one of the challenges, obviously, in racing is that you have tracks, multiple tracks in different states, and each of those have slightly different ways of doing things. And there's often not a consistency when it comes to the medical management piece. And that has challenges on several levels. And one of the advantages of potentially having an organization of a medical management that would deal with medical management education is it would be independent. It would certainly have to be tied to the industry, but it could present and provide data, and it could provide guidelines and best practices for the industry to implement. It would be coordinated with multiple industry organizations. It would provide a consistency of care. So if you think about the consistency of care that now takes place, it's varied. Dr. Hitchens' data related to catastrophic injuries, very, very important. But what we often forget is the nagging injuries and day-to-day injuries that take place that are often not evaluated or taking place. And I think Dr. Ryan's going to touch on that as well. It would be similar to other sports groups. And it would allow us to have accurate record keeping. So one of the challenges is not having a medical professional in place at the tracks is the actual data that takes place related to their medical information injury is haphazard, to say the least, because there's not someone there that's specifically in charge of that. The other piece that would be really important for us geeks is the data. So So we're in a society where much of the decisions we make, specifically in other sports, are driven on data. If you look at the rules and changes that have taken place in the NFL, that's because of research and data that's presented to that group to say, this is the reason you need to make these changes. That's lacking right now in the industry. This model basically is very similar, other than I have the other constituents and industry leaders that would participate in this, would have to collaborate and participate with a medical advisory group or committee, however you want to think about it. And to me, it flows up and it flows down. There'd be education that would help drive recommendations from the committee, and then the individuals working at the bottom in the blue, the healthcare providers, which to me makes the most sense, at least the model that we had here at Keeneland, which was a medical director and or athletic trainer. They would provide the day-to-day care, the acute care, the record keeping, the referral, and they would also help generate data that would inform the industry to make decisions. And to me, that's the piece I think that's really exciting in the future. In addition to that, that's infrastructure, that's committee. I realize things move slowly in professions and industry, and so that's going to take some time, I think, to develop and have people sort of work through if they think that's a reasonable idea. Certainly an idea I see happening and have incorporated a couple different professions into that, is the education piece is going to be very important, both for the individuals that are providing care as well as to the industry. And then having situations like this where we can share that information. So whether it's at the Safety and Welfare Conference or there are specific conferences that deal with these aspects, the medical management aspect and care and safety. Important, cultural change and resources. One of the things we've certainly demonstrated, and Kelly's demonstrated at MedStar, is that if you have a trained healthcare provider there, you can get the baseline assessment, you can have assistance with the health information, you can actually implement a return to ride protocol, and you have proper medical care and referral. Not just for the catastrophic injuries. Those are, I won't say it's easy, but if it's a catastrophic injury, your paramedic is going to move somebody off the track and get them to a trauma 1 center as quickly as possible. It's the pieces that are not necessarily always counted, I think, that we're missing. I want to highlight a few things. Some of the exciting pieces of my interaction with this group in the industry is we have developed and expanded some of the research we're doing at the University of Kentucky, both myself and some of our faculty, College of Agriculture, College of Public Health. So there's a large group of folks that are working together. And in our laboratory, we've actually added some really amazing and fun instruments, and I just wanted to highlight a few of that. So some of the research and clinical benefits that we see our laboratory providing and the University of Kentucky providing is optimizing training, as well as looking at performance of injury and biomechanical assessment of riding mechanics. And so we've had several fun studies. I'll just highlight a couple. We've been working with the North American Riding Academy, and we've actually been testing their young riders as they've learned the ropes of becoming a jockey from the start to the finish of their training, with the goals that that information will then be incorporated with information from professional jockeys, and we can begin to build a biomechanical profile of what an amateur, novice, and professional rider looks like. And so part of that assessment is we actually bring folks into the lab, and Donna's been there, and I appreciate her coming. I didn't put your video up here, although if any of you want to see a really cool video, I have someone that might be the moderator today in high heels riding a mechanical horse. I'm going to show in a little bit, but I didn't get a permission to show that beforehand. So we do a biomechanical assessment on a racewood simulator. We do a full body composition, strength, balance, and several other psychological tests as the riders come through. If you would start that video, it would be great. If it's going to fly. No? We had some issues with it uploading today. Okay. No dice, Shannon? Oh, cool. So what we do when folks come into the laboratory is we actually put little markers on them and the horse, and we can develop a complete profile of what that person looks like, a biomechanical profile that measures joint position. And so here we have an ex-famous jockey who came into our lab and is great enough to do some riding. And basically what we did, that's a short snippet, is we would have the riders ride 3 races at a 7 furlong pace. So they would replicate basically a race on that simulator. The nice thing about it is we can then look at fatigue, and we can look at their position and biomechanics related to other groups. Also really excited, we've launched a new initiative called the Jockey Equestrian Initiative. And the focus of this is several things. Our mission is to provide and be available for performance, biomechanical, as well as psychological and occupational issues related to equestrians. Not just jockeys, although certainly much of what the work we're focusing on has been related to jockeys, but equestrians in general. And so that's been very exciting. And we've got several faculty at the University of Kentucky and some faculty outside of the University of Kentucky that we're including in this initiative, and we're excited to move this forward. I just want to say thank you, and appreciate the opportunity to highlight some of the work that we've been doing.
Pull out my timer. Hi, so my name is Kelly Ryan. I am a primary care sports medicine physician. Has anyone ever heard of a primary care sports medicine physician? Raise your hand. Okay, a couple. And how many people here are veterinarians? It's a lot. How many people here are medical doctors? Oh, very good. So this is just something that I wanted to present to you, was our world at Maryland Racetrack, which is unique for the horse racing industry, but is not actually really as unique as everyone thinks. Everything kind of came together, but it seems to have worked out pretty well for everyone. So what I do essentially is I specialize in sports medicine. I have my regular family medicine practice that I do anywhere from newborns all the way up to my oldest patient's 96 years old, and we do anything from colds to injuries to cancer to screening, all that type of stuff. But then I did an extra year of training specifically in sports medicine. My fellowship director is actually one of the head team physicians for the NFL and works with the Baltimore Ravens. So I learned a lot from him, and I learned a lot from college physicians and things like that. And when I was graduating from my fellowship program, I was looking for a job, and the racetrack was looking for a doctor, and somehow we matched up, which could be pretty scary and was very difficult to conceptualize that I would be working at a racetrack after watching some of those injuries when I was actually scared to treat strep throat by myself. So I just wanted to talk a little bit about the sports medicine model, why it works well, about how we do our return to ride protocols, and also to discuss maybe how you could implement some of these ideas and concepts into your racetracks. So what do we do best? We take care of athletes. We specialize in heat illness. We take care of specific orthopedic injuries. We take care of concussions, and this is what we know. And we're always on the sidelines. We're out on the field. We do emergency medicine, but we also do prevention and rehab. So this is my team. My team are my jockeys. I've actually spoken with about 4 of them today already about their injuries, just to see how they're doing and see how they're progressing. So what specifically is a sports medicine physician? I kind of already went into that, but again, we're on the sidelines, we're in the training rooms, we follow up with them, and then we also help to set rules and protocols in the case that there is an emergency that we would have to be present. There is absolutely no predicting what's going to happen on any given day when you're covering. There's a lot of doctors that sit in an office. There are very few doctors that think when you drive to work, someone might die today, and I'm going to be the one that's going to have to be responsible to take care of that person in that situation, which is pretty frightening. So the other thing, though, is that we also lead our pre-participation physical exams, which is a really important part of sports medicine, although not necessarily as critical for our jockeys as a lot of our racehorses. By the way, just a disclosure, I am not a horse person. This world is completely new to me as of the past 2.5 years. I've learned an incredible amount on the job, maybe even more than medical school. But the race horses actually get evaluated every single race, whereas some of the jockeys don't even get evaluated every single year. There are things that jockeys and other athletes are very specific to their concerns, such as sudden cardiac death of an athlete. heat stroke, concussions. These types of things are things that you might not get during your regular during your regular physical or preventive care, but is very specific to athletes, like when a basketball player collapses on a court. These are the things that we're trying to prevent, and we're trying to do it in a very specific fashion, because I'll tell you what, my jockeys are completely different than any other person or athlete for that specific matter than anyone I've ever taken care of before, and they have specific needs that are to them. A lot of times there are some things that we can cross over, you know, race medicine, dealing with heat illness and things like that, weight management with our gymnasts, but these are things that we can actually address and apply specifically to our athletes at the racetrack, including also sports psychology and making sure that they're ready both mentally and physically, because it can be a really demanding and very difficult sport to be involved in, especially when you're coming back from an injury and you have all the pressure of the trainers and the industry looking at you, waiting for you to ride when you don't really feel like you are ready. So injury management, again, we do a lot of orthopedic stuff. There's a lot of concussions that we've been talking about. I feel like that's been my entire life for the past 2.5 years is talking about concussions, but we do a lot more than just that. So what happens when there is a fall? So once there's a rider that goes down, then EMS is always there, and that's not my job. My job is not critical care medicine at that time, and that's not what I was trained to do. So if there is a really bad fall, EMS is there to pick them up. I usually will try to run out onto the track and meet them where they are, because I am a physician and there are things that I'm allowed to do that the EMS, and whether you're a paramedic or whether you're an EMT, are not allowed to do. So I do try to make sure that I'm there. I also know all of the athletes. I know all of their ailments. I know all of their medical history, because I was the one that did their pre-participation physical. I know which one has an allergy to what medication, and I have all of their records, because we were able to take all that information in our pre-participation physical. What happens then is we determine, is this a life-threatening emergency that needs to be transported immediately, or is this something that we could actually take back to the paddock and go back to the jocks room and have them sit for a couple minutes and see and reassess and determine whether or not they actually need to be taken out of racing. And then once we're able to determine whether it is a life-threatening injury or whether we can just watch them, if they are going to the hospital, I pull their records. I actually go back to the trailer and I will re-watch the race. I'll call the hospital ahead of time, say, this is a rider that came off of the horse going 40 miles an hour. He was run over by another horse. He was clipped. He rolled on his right side. And that gives them a lot more information, because when you go into an emergency department and they have their paperwork, complaint, rider fell from horse, well, there's a lot of differences between just a rider falling from a horse and a rider falling from a horse the ways that we've seen them. So it's really important to make sure that the medical personnel at the emergency department recognize this, because they might need a CT scan regardless of how they're feeling, just based off of trauma mechanisms. If they're able to be monitored there, then I'll take them back to the jocks room. I'll let them clean up a little bit. They have all that adrenaline going through them. They might not be having a great exam at that time because they don't necessarily even recognize that they're injured. I give them some time, and then I'll come back and I'll see them again. And then what happens after they had an injury? Well, if they had an injury and they went to the emergency department, I make sure that I call the ER and say, before they are released, I'd like to understand what was their course of action while they were in the ER and what kind of follow-up do they need. Did they have imaging? What kind of imaging did they have? Did they have an X-ray, or do they might possibly need an MRI in the future? So many of my jockeys will come in and I say, well, what did they do for you at the hospital? Oh, they scanned my whole body and I'm okay. So, that's completely different. I had a rider who actually had an ACL tear, and it told me he had his whole body scanned and everything was fine. I looked at him and immediately knew exactly what his injury was, just based off of dealing with other athletes and things like that. But there's a big misconception between the medical world and people who are not medically inclined. So then what we do is I make sure that I follow up with them at the jocks room. I make sure that there's no ailments that are continuing to occur, that they are not having any continuing problems, and that really I'm able to follow up and make sure that they get any further medical care that they need. Do they need physical therapy? Will they possibly need any advanced imaging? Things like that. So here are our numbers from Maryland Racing. So as part of just being a clinical physician, I was able to pull all of our injury reports because I use them for our workman's comp claims. And you can see that we've had a total of 91 injuries in this time period. And you can also see that 69 of them were actually handled at our racetrack without having to go to any other facilities. And just to put that into perspective, I am expensive. It costs about $230 to come see me for a 15 to 20-minute exam. I don't necessarily make all of that, but for insurance companies and things like that. And so that's a lot of visits. And I not only just take care of the athletes at the racetrack, but I also take care of the backstretch employees. One of the other things that, like I said, we've been talking about nonstop for the past couple years that everyone says, Maryland, they're doing it right. This is so unique. What we're doing is not unique, actually. It's just in a different setting. We do concussions all day, every day, in many different athletes. It's just a matter of taking what we knew from the sports medicine world and applying it to what we know about horse racing. Difficult with diagnosis. Concussions are one of the most difficult things to really comprehend, even as a medical professional. I take care of residents. I'm a faculty professor at my residency program, and a lot of doctors are not good at diagnosing concussions. They really don't understand it. You really have to be involved with it, and you really have to understand, and you have to see it, and you have to have seen patients who have had concussions because it's very confusing, especially when you come off of a horse and you have all this adrenaline going through you. Sometimes they feel like they're okay, and the next day they'll say, actually, you know what? I wasn't okay, looking back. So this is what we're doing, like Carl had talked about. We're using our CAT5, which is the guideline and the gold standard for concussion evaluations in all of our other sports, so why not use it at the racetrack? So what we're doing is we were actually doing our baseline concussion testing with our pre-participation physicals, so I do their concussion testing every single year. Now that being said, that is 10 minutes that I have with my jockey that I can talk to them about concussions, because one of the biggest parts about concussion is actually education. They don't necessarily really even know what a concussion is. A lot of people just think that it's just a headache, but they don't necessarily know that you might feel tired, that the lights might bother you, that you might feel confused or dizzy. They don't necessarily know that. A lot of them never even finish school. So this is all very new, and it's a difficult concept. They just know they don't feel right. So anytime that a rider comes off of a horse at our racetrack, we go and evaluate them, and we would do the CAT5 if we feel that it's necessary. And then if there's any suspicion or question of a doubt that they might have sustained a concussion, I will pull them and then reevaluate them the next day. I make sure that they don't go home alone, and I make sure that I educate the person, whoever they're going home with, worsening signs and symptoms, because in a lot of our other sports we worry about concussions. In this sport, I worry about intracranial hemorrhages. It's different. These traumas are different than you just banging your head against each other during a game maybe 50 times. This is high-speed trauma, and from a medical standpoint, it's very different. So these are some of the things that we've been doing, that we've been working on. Been working with the Jockeys Guild, which has been wonderful, and working with University of Kentucky, which I think we're all on the same page here, that the sports medicine model is really the way that the industry should be looking. In the past year, we've done a lot more. It's been a little bit of an exponential rate here, but we have amped up our pre-participation physicals. We've done our baseline concussion testing. We've included a form that they have to sign that says that they've been educated on the risks of concussion if they feel that they are suffering from a concussion, or if they have suspicion that another rider might have a concussion, that they will notify someone. And this is similar to all the other sports that we have. I've also created a concussion video that talks about if you have a fall, this is what we might check you for, this is how you might feel, and this is why it's important. And so if you go to YouTube and you look up Horseman's Health and MedStar, you'll be able to share that. And we've actually used that as part of our new license for our new riders. They actually have to watch that and sign off that they've been educated, and then they at least have had some sort of education and can get a better understanding of what might happen during a race day if they fall, and so they're not surprised and say, whoa, what's happening? And again, one of the other things that we've been doing is a return to ride protocol. So once you have an athlete that's had an injury, you want to make sure that they're safe, not necessarily just to walk and that they feel okay, but you want to make sure that they're safe to get back up on a horse. So one of the things that we've developed is a return to ride protocol, which is not something new, again, in our concussion management. However, we've just adapted it to horse racing. So in most of these steps, the way that you do it is it's a stepwise progression, but when we initially got there and we didn't know anything about horse racing, we came up with this idea in our head, and it actually was dangerous to put them back on a horse too quickly, so I moved that step back. And with Carl, he's actually been able to reproduce some of this in his lab, and we found out it actually works pretty well. Sometimes you might think that you feel fine until you exert yourself, until you really increase your intensity, increase the blood pressure in your brain, and then you might start to have symptoms again. It happens all the time. So it's nice to be able to test them in a safe environment, because if you were to get a second head injury before the first head injury has improved, that's when long-term problems and complications really happen in a prolonged recovery. And then one of the last things I want to talk about, so okay, we don't have enough money to have a fancy sports medicine doctor. You know, Kelly, you're one of a kind. Well, my mom thinks I'm pretty cool, but I'm actually not unique. So there are a lot of primary care sports medicine physicians out there, and there's an entire network, the American Medical Society for Sports Medicine, and I've actually gone to them and talked about you. So, you know, you can find local physicians around your area. Maybe they might not actually be able to provide coverage for you at the racetrack, but at least having a system that if there was an injury, that they will be able to get them in the next day. Sports medicine doctors love this kind of stuff because it generates revenue for them, and because they really like this stuff. You know, it gets us really excited. The other thing that you can do is also there's something called athletic trainers. So they're really like our eyes and our ears on the field when we're busy in the office making those co-pays. So what they do is they actually will call us and say, I have this injury, what do you think about this? Can I get them into your office? And they're very proficient in these types of injuries, and especially in concussions. Paramedics and EMTs, is this a life-threatening scenario? Do I have to resuscitate them? Well, that's one aspect of it, but for athletic trainers, it's how can we get them back to what they're doing? They're two completely separate fields, but I think having one of everything at the racetrack is very good, and athletic trainers are much more affordable than I am. So here are some of the things that we've done. So we've actually added AEDs to our racetrack, and it was ironic and helpful that I actually ended up resuscitating a groom who had collapsed at the paddock. Within 2.5 minutes of his collapse, luckily because our entire team had just been trained on CPR and we had AEDs available. We've also done mass casualty practice as well at our racetrack. We had flu vaccines. I gave out tetanus vaccines because horses actually carry tetanus in their mouth, so we made sure to do that. We've been involved, like I said, with creating that video, and we've also had some equipment donated to the racetrack. And then other benefits of a racetrack physician. So guess what? Everyone is worried about workman's comp. I'm a good solution to that because I have to send a lot less of my patients to workman's comp because I take care of them in my office. So that's one of the great benefits of having a physician there. I do occupational medicine, I do preventive medicine, and I also take care of the jockeys. Again, with preventive health, I also take care of the backstretch employees, diabetes, high blood pressure, horse bites, after horse contusions, fractures. I've looked at x-rays from vets, which is new to me. Some of the other things that we've done, we've actually diagnosed cancer and actually was able to get a man in to get insurance when his symptoms first started, and thank goodness that we did because he actually did have cancer and he was able to get treatment only because he came to see us first and we were able to assist him in these types of things. And there's countless stories that I could tell you about these types of injuries and problems that have happened that were saved because of racetrack medicine right there on site. So, any questions? Which one? Just give me my... Sorry.
We're working on it. There we go. Okay. First question was, how can team physicians already involved in professional sports get involved with racing injury research? So that could be for any of you. If you want to take a stab.
Team physicians was the question?
Yeah, the actual question is, how can team physicians already involved in professional sports get involved in racing injury research?
So that would be fantastic if we had more sports medicine physicians that wanted to be involved. And like I said, I had actually spoken recently at the American Medical Society for Sports Medicine to reach out to them and say, hey, there's this amazing world with these incredible athletes, and there's so much opportunity there. I would like some help. So if you just have to reach out to your local organizations or local racetracks, again, and establish relationships, which would benefit both not only research but also the tracks themselves, to create relationships like that that benefit both sides. It's a symbiotic relationship.
Okay, and then this is actually for you, Dr. Ryan. Do you feel every track should have an athletic trainer?
That is a great question, and I do. I do believe that every racetrack will benefit from an athletic trainer. If I had it my way, I would have myself as a primary care sports medicine physician. I would have an athletic trainer who is not only able to assess injuries, but they also do treatment. It's kind of like a mix between a doctor and a physical therapist, and they're very good at what they do. I work with them in multiple different arenas, and half the time I'm like, I don't even know why I'm even here. Why are you even asking me about this? You clearly have this under control. And then I also would love to have a physical therapist at the racetrack, but I think if you're limited in your budget, I think it's a really, really great option to look at. And how do you go about doing that? Well, you could look at the NATA, which I'm sure Carl could probably talk about a little bit more, but really just reaching out to local sports medicine groups in the area. All you have to do is Google it and just saying, this is our situation, this is what we're trying to do, this is what we need. And I just want people to stop saying, oh, it'll never work. It won't, it's never going to work like that. Just try it. It might really work very well.
Can I add something to that? I think that the information that Dr. Hitchens provided related to medical claims is really important. If you look at the work that Kelly does and you look at the ability to provide acute care and continued care, those claims would be decreased relative to the cost of having someone on site. The other things that I think about, in the 80s and 90s, it was hard-pressed to find an athletic trainer at a high school. Now most athletic trainers are at high schools and or have a team physician that may or may not work with them. Certainly that is the complete model in college, and certainly that's the complete model in the professional sports. So adapting that model, I think, right now provides the industry the opportunity to ramp up care, for one, and then really all those things that we tried to portray in that model, which is the ability to collect data, the ability to have appropriate medical information. The one thing we haven't talked about is that getting that information from the track to the hospital or to provide it to a family and having that be accurate. So there are things in place right now to provide that information, but oftentimes that information may not be as accurate because someone hasn't been there in the trenches on a day-to-day basis to be able to manage that. The other piece that's really interesting and I think makes this exciting from a challenge standpoint, and that is because tracks are, because there's differences between states and the tracks are more independent than you would think of other professional organizations, having the infrastructure where someone could coordinate that and there was some way of pulling everybody together so that they were sharing the information, they were HIPAA compliant, and they were all working towards a common goal. That's going to be a little more complicated than it is in some of the professional sports, organized professional sports, but I think is certainly capable as we move forward.
I think one of the other things to briefly mention is I work for MedStar. MedStar is a very large health organization. I do not work for the racetrack. I work at the racetrack, but I do not work for the racetrack, which saves a lot of legal hassle because my company takes care of medical problems all the time, and they pay for my liability. And so there's a contract, and it's a relationship, but I'm not employed by the racetrack, which also keeps me, as in the NFL and all other major organizations, that keeps me from having interest in that specific jockey and is able for me to be able to make the best decision for that medical care.
One more question for Dr. Mattacola. In considering a protocol for identification and treatment of jockey concussions, are you familiar with the iPAS goggle system recently implemented in IndyCar? And if so, do you think this technology could be adapted to jockeys or even in the future horses themselves?
Can you tell me the name again?
It says I-PAS, I'm guessing iPAS, goggle
iPAS.
system.
I am. I actually just returned from Minneapolis last week. Dr. Havoda, didn't get a chance to meet her, but several folks in industry. There are some really cool additional adjunct pieces of information to provide objective data related to concussions that I think will become commonplace in the future. We're not there yet, but eye tracking is one of them, and there's several companies. There's one called Oculogica. That's the one I visited last week to identify if it would be if and how it could be an integral part of what we're doing from our research perspective. But yes, I think as we move forward, all the objective data that we use to identify and or confirm if somebody has a concussion is going to continue to improve, and we'll begin to build algorithms that would provide a physician or athletic trainer the ability to make informed decisions and have that data. The idea of the visual tracking is that, oculomotor 3 and oculomotor 6, your oculomotor nerves, your cranial nerves 3 and 6, if compromised, your visual tracking is compromised, and oftentimes that can occur when other signs and symptoms may be diminished. So someone may say they're okay, but it provides an objective way to look at those cranial nerves. The challenge is there's several other cranial nerves and there's other signs and symptoms that are available or that are present. So incorporating all of that, I think, in the future will be really important as we develop our protocols.
Great. That's all the questions we have. I'll throw it back to Donna.
So I just had one last question for you all. It sounds like Maryland now has a protocol for baseline and Kentucky has a protocol for baseline, but do you know of any other racing jurisdictions as a whole have these protocols for baseline examinations for concussions and just health overall?
I wouldn't say overall for a state, but there are some tracks that have adopted baseline concussion testing. The challenge, Donna, is it's positive. The tracks want to do the right thing, but right now the coordination piece is difficult. So we've obviously been working with MedStar. Jeff Johnson's been working with, and I've had some conversation with a track in Indianapolis. But the coordination of actually having someone who is the representative for that track and that we're integrating the data consistently in the same database and we're not replicating it. One of the things we found in the last few years is several tracks are now doing some baseline testing. So now if a jockey goes to a particular track, it's redundant to have them do the same test over and over. Mm-hmm. And so one of the things that we've been able to establish as part of this pilot project is that at least between us, I'll say Kentucky, and MedStar, we are coordinating the medical care piece. We're using the same baseline assessment. We're sharing that baseline assessment so it's not being done repetitively. And there's a conversation if someone is disqualified. So Kelly sees someone, at least we've had the opportunity to have that connection where we can share the information and say this person's not allowed to participate or this person has been released. And so that's the piece I think we're getting to next is how to incorporate it.
So real quick, for any racetracks out there who might be listening in and want to implement this, do they have to have a particular type of software, or are you just able to share reports with baseline data that's a simple document on that person?
The Jockey Health History Database is present. It was created by the Jockey Club with Encompass. So that is established. We're working on improving some of the ability to make it a little more nimble. So that's available, and so a representative from the track could have access to that. And so it's really the coordination of improving that and having someone that would be identifiable as that individual.
Great. Did any of you have anything you wanted to add?
So I briefly just wanted to discuss baseline concussion testing, especially because I feel like that's actually the question that we get asked the most is, what do you think about baseline concussion testing? Well, there's a lot of different components of concussion. If you're a racetrack and you have nothing in place, your number one priority is verbiage in your laws or regulations that say if there is a suspected concussion, that rider is not allowed to ride until they're evaluated and cleared by a person who is trained in concussion evaluation. That is your number one priority, is protecting those jockeys. Baseline concussion testing does nothing if you don't have someone who can interpret that data on race day. So your first thing is actually is rules. Number two is education, at least educating your rider, and I feel like baseline concussion testing does both of those things, but everyone's talking about baseline concussion testing, and it's kind of sexy in the sports medicine world, which one, impact, SCAT, whichever one. Everyone is coming up with something new, but again, as regulators, your number one priority is that if a rider comes off, has a head injury, has any kind of suspicion that they're removed from riding, and figuring out a way to make it work. Because a coach can pull a player off of a field if there's not a doctor around. Enough people know about concussions that needs to be at all racetracks, and that's your number one priority.
All right, well, thank you all, Dr. Hitchens, Mattacola, Dr. Ryan. Thank you all.